So we're really thrilled to introduce Dr. Spargias, who's calling us from Japan. Dr. Spargias, my name is Teresa Glenn. I'm in the room here with 32 participants from 17 countries, all representing the patient voice. So we're really thrilled to have you here. We've done your introduction earlier along with the rest of our faculty. So we're very excited about this session relating to the guidelines and understanding the guidelines. And I know you have some slides, and then we'll open up for questions from the audience. So with that, unless you have any questions, I think we can get started.
Great. Thank you for having me, and thank you for the invitation. Calling from Japan, it's early evening here. Good morning to all of you in Ireland. And thanks the Global Heart Hub and the International Alliance of Heart Patient Organization for the invitation. And the topic I was asked to cover is what the guidelines say, and understanding why and when a treatment should be given to a patient. I'm an interventional cardiologist, so this is my main disclosure. So I'm doing what interventional cardiologists do. So I'm certainly biased towards them. And you shouldn't forget that. So these are my disclosure. I cooperate with device companies. Mainly, I'm an early adopter of new devices, new therapies. And in some of them, I was also involved in the designing, developing a device and early animal and human trials. And this is the heart team at the Yale Hospital in Athens, Greece. Dr. Professor Sadari knows most of us, and thank him for the invitation also and involving me. So the guidelines. We have guidelines that are coming from various scientific societies. The European Society of Cardiology is the biggest scientific society of cardiology in Europe, and they produce and give us guidelines every year for various diseases. As you can see here, just for 2023, we have guidelines for cardiovascular disease and diabetes, for cardiomyopathies, for heart failure, endocarditis, acute coronary syndromes. And you see yearly we have a production of 3 or 4 guidelines for diseases, covering diseases in cardiovascular field. So you go back to 2002, I think the beginning of this century marked the beginning of producing guidelines, understanding their significance, and putting a lot of work by international societies to produce guidelines to guide us for various diseases, how to treat them and how to assess them. So since my main interest is valvular disease, I will take you through the journey of guidelines, through the guidelines of heart valvular disease. And these are the latest guidelines produced by the 2 largest international societies of cardiology. So the first is the European Society of Cardiology in 2021. So these are the latest guidelines we have for valvular heart disease from Europe. And then we have the American College of Cardiology and the American Heart Association joint guidelines for valvular heart disease. And the latest update is from 2020, 1 year earlier. I should say, as you noticed earlier, guidelines are produced every 3 or 4 years. So we expect, and you see the past guidelines for valvular disease by the European and the American societies through the year. So they're coming every 3 or 4 years. So 2020, the American, 2021, the European, we're expecting probably this year or next year to have an update on these guidelines by both societies. So first of all, let's understand what a guideline is by just seeing the preamble of the European guidelines I've just shown to you. So guidelines summarize and give us the available evidence with aim to assist us for the best management of our patients and try to find out the best treatment for an individual patient based on all this concentrated and accumulated evidence the guidelines provide to us. So they give us recommendation to make a decision, but they're not, it's not a law. It's not like a rule that we should always follow. And this is what they say: the final decision concerning an individual patient must be made by the responsible health professionals. So this is how the guidelines are defined in the European edition, and this is exactly the same by the American edition. So provide recommendation applicable to patients who have cardiovascular disease, and they are mainly for the United States, but they say, but these guidelines are relevant to patients throughout the world. And they accept that they're used more and more nowadays to inform regulatory and payer decisions. And again, they say they're used to improve the quality of care of our patients, but they should not replace clinical judgment. These are the authors of the European guidelines. You can see they're coming from many European countries, and there are many of them. So how were they selected? How are they selected? Because this is very crucial in the guidelines. Who are the people who write the guidelines? Who are the people who make these decisions? So in Europe, they're selected by the European Cardiology Society and by the European Society of Cardiothoracic Patients for the valvular guidelines. So these are two professional and scientific societies, and all the members of these societies are elected by cardiologists in countries, individual, and then in the main yearly congresses, there is selection of the European Council of these societies. So we vote for the people who are the members who govern these societies. And then we also have these subspecialty groups within the society. So within a society, you'll find a working group on heart failure, a working group on coronary artery disease, a working group on various fields of our specialty. And these are also people we vote for them within our countries and then within Europe. So all these people are elected, and they gather and they decide, they make a decision who is going to participate in these guidelines. And this is very important to know. And for the European guidelines, we also have the document reviewer. So these guidelines are reviewed by all these people. So you see a representation of all the European countries. So multiple reviewers. What happens in the US? We have the joint committee of the two professional societies, the ACC and the AHA, and they decide who will participate in the writing of these guidelines. They want to have expertise and to be representative of all the cardiovascular community. They do not only have cardiologists, as happened in Europe. In Europe, we have cardiologists and cardiothoracic surgeons for these guidelines, for the valve guidelines. In the US, they have cardiologists and surgeons, but they also have anesthesiologists, and they also have a patient representative, very important. And this happens in the US. And again, they have the review process that is very meticulous. They have two official reviewers by the two societies, and then they have multiple content reviewers nominated by these two societies. So how many papers, how great is the diving in they're doing into literature to come up with these guidelines? The first is just a snapshot of the last page of the references of the European guidelines. So you see they used 562 publications. So they cite 562 publications to end up with these guidelines. And on the other side, the American guidelines double this number. They cited more than 1,000 references to come up with these guidelines. So this is an enormous task that probably one of us individually will be very time demanding and almost impossible to do. So that's why the guidelines are very useful, because they gather all this science together by many people that are very, they are specialists in the field, and they give this information and data ready to us. So then the very important thing is to understand the recommendations of the guidelines. And this is like the Bible of the guidelines. This is what we're using every day in clinical practice. And most of us, we also pass this information to you, to our patients. So we say this is absolutely recommended or indicated. When we say this is class 1 indication, which means that the evidence is great, that this therapy must be given to a patient with a given disease, and there is general agreement that this is true. And then we have class 2, and class 2, as you can see, can be classified to class 2A and class 2B. So this is the class that we have most struggle sometimes to decide if a therapy should be offered to a patient or not. So here we have some evidence that a therapy or a treatment is beneficial, but this evidence is conflicting, and the opinion is not always agreeable about the usefulness and the efficacy of this given therapy. When we're in class 2A, then probably this therapy, the weight of the evidence leans in favor of this therapy. That's why we used that this therapy should be considered. And when we're in class 2B, then the evidence is less well established. That's why we say we may consider this therapy for this patient. And finally, class 3, very clear that we should not offer this therapy. There is no evidence that this therapy is beneficial. There may actually be evidence that this therapy is harmful. So these are the classes that we're using every day. When we say class 1 between us, we know that this therapy should be offered. Class 2, then if it's 2A, most of us, we agree it should be offered. 2B, special circumstances to offer this therapy. And 3, of course, never offer this therapy. And then we have, apart from these classes of evidence, we have also the level of evidence. So level of evidence A, B, and C. So for each of them, we make a conclusion based on some data. If this data is and cannot be challenged, and it comes from very solid evidence, then this is level of evidence A. And what do we consider level of evidence A? This is the multiple randomized clinical trials where we randomize patients to this therapy versus nothing, versus placebo, or versus another therapy that we want to compare with. So this is the randomization process. And what evidence we get from these randomized trials, we consider in medicine the most solid evidence, or from meta-analysis of multiple such randomized trials. So when we have level of evidence A is the strongest evidence. When we have B, it's somewhere somewhat less. So it comes from just one randomized clinical trial or from observational studies, not randomized. And level of evidence C is based mainly on consensus of opinion of experts, or coming from very small retrospective studies and registries. So we have class, and then we have evidence. That's why you may sometimes see class 1, but evidence C. So class 1C, it's absolutely recommended, but it comes from consensus of opinion, something that is very widely believed by experts, and nobody's challenging it. Or class 2A, B. So all these combinations are possible. Now let's move to the American guidelines. They give more wording on what we just said. So class 1, indication, something that is recommended, indicated, effective, beneficial, should be performed, and the comparative effectiveness is confirmed. Class 2A, similar to what we said earlier by the European guidelines, this therapy, the wording is reasonable, can be useful. Class 2B may or might be reasonable, may or might be considered. So in class 1, the benefit, it's clearly very, very large and much larger, so outweighs any risk. In class 2A, the benefit is bigger than the risk, clearly. In class 2B, the benefit may be bigger, but may also be equal to the risk. And of course, class 3, no benefit, or it may actually be dangerous. And again, in the American guidelines, we have the same level of evidence like we described in the European guidelines, very similar. So I don't need to go through this again. So level of evidence A, very solid evidence from very good randomized trials or meta-analysis of randomized trials. Level B, just one randomized or multiple small observational studies or meta-analysis, but many of them, they all point towards this direction. And level C is the one that is coming like from consensus of experts in the fields without any doubts, without any
organs in the
questioning.
body, working relentlessly to enable the
So
human
if we go
cardiovascular
now
system.
to see just an animation, a cartoon of the valves, because we're going to talk about the valves. This is the heart with the 3 main valves. So this is the aortic valve on the top, this is the mitral valve, and this is a tricuspid valve. The 4th one is the pulmonary valve, but this is not usually something that is a problem for adults. Pulmonary valve problems are only for neonates or babies, very rarely for adults. So the 2 valves that separate the upper chambers of the heart and the lower, the mitral and the tricuspid, they close when the valve contracts, so they prevent blood going back into the atria. And then the aortic valve is the valve that the blood exits from the heart and goes to the body. These are the 3 main valves that they have diseases in adulthood. So by comparison, in the US, this is data from the US, at any given moment, there are about 1 million patients with significant aortic stenosis. As you can see, about 1.6 million with significant tricuspid regurgitation and 4 million with significant mitral regurgitation. So this is the incidence of these valvular diseases in the general population. You can do your maths on your own. And this small blue cube down here, it shows you how many of these patients are actually treated in the US. So you'll see just a very, very small fraction is treated. Just a correction, this is not only significant, but also moderate. M is for moderate. So probably half of them is significant. But again, even half of them, if it's significant, you see just a very small proportion is actually treated. And this, in probably the most developed country and society in the world. So you can expect the proportion of those treated in other countries, especially in the third world, to be like even much lower than this. So by incidence, the most frequent valve disease is mitral regurgitation. The second most frequent is tricuspid regurgitation. And the third most frequent is aortic stenosis. But you see the proportion of the treatment, it goes the other way around. So most of the aortic stenosis patients, the proportion of them treated is higher than any of the other two. What we see in both the European and the American guidelines, just in this last version, is this concept of heart team, heart valve center of expertise in treating valvular disease. This is something we're discussing for years before, but it comes like to realize and to put it down in writing in the latest guidelines. So if we want to offer the best therapy for valve disease, we should work together. It's not a work of just one doctor. We should come together, cardiologists, interventional cardiologists, surgeons, and imaging specialists, anesthesiologists, people that are doing this job every day, 24 hours a day, 7 days a week, and knowing everything that exists in the field, not only knows, but also use these therapies. And then we take out the bias, because as an interventional cardiologist, I do interventional thing, but I also work with a surgeon who is doing the surgical therapies. And then we come to discuss together one patient, and we have to come to a consensus, having all the knowledge between us, which therapy is better for a given patient. This is very important. And then we have the tiebreaker. The tiebreaker usually in valvular disease is the imaging cardiologist, who is not doing the interventional procedure, is not doing surgery, but he assists us doing the echocardiography, so the imaging during whatever procedure we select. So probably he's the best person to know both options, interventional and surgical. So that's why we respect their opinion very much. So if we have these heart teams and the heart valve centers that they apply as these therapies, then I think the bias goes away, and we know that as a patient, that if I go to a heart valve center, I will be offered the best therapy, personalized for me, and not just go to a place where one therapy is offered but nothing else. So is it a time now to just give you some examples of how we make the decisions by using the guidelines in individual diseases, like we talked earlier, starting with aortic regurgitation. So the aortic valve, as I explained, is the valve where the blood goes out of the heart, pumped out of the heart to the body. And usually in diastole, this valve closes, so it doesn't allow the blood to go back to the heart. And if there is a pathology like you see here, where the leaflets of the aortic valve don't seal the valve in diastole, then the blood comes back to the heart. So this is a useless pumping action, and all the blood that is pumped out is not offered to the body, but much of it is coming back to the heart, creating a lot of problems to the heart and a lot of symptoms to the patients. So to make a decision, first of all, we use echocardiography, so the ultrasound of the heart. We have to decide if aortic regurgitation is significant or not. So we have very, very well-established criteria that are in this table by using echocardiography, quantitative, qualitative echocardiography, to decide if the aortic regurgitation a patient has is significant or not. Because if it's not significant, then it's just follow-up. we follow up the patient for deterioration, for signs that it's becoming more significant, follow up echocardiography to see what is going on in the future, and also prevention by various pharmaceutical drug therapies. But if it's significant, then we should offer treatment. And what is the treatment? The treatment for the time being is surgery. So we have to replace this damaged aortic valve. And we have all these indications for surgery as I presented to you earlier. So now you know to judge these indications, how to judge them. You have class 1, absolutely indicated, level of evidence. So for these two is B, quite strong. And then we have 2B and 1C and 2BC. So level of evidence C, it's expert consensus. So first of all, 1B, if a patient is symptomatic and has severe aortic regurgitation, the patient has to undergo surgery. So there's no question about this. And if the patient is asymptomatic, but we have some signs that the aortic regurgitation is advanced on echocardiography, then again, surgery is absolutely indicated. Now, if we get patients that are asymptomatic, they have some signs that the aortic regurgitation is advanced, but not to this level. If you get the numbers, you'll see the numbers here are worse by the numbers here. Then you can say some believe, level of evidence C, that these patients may also benefit from surgery. We shouldn't wait longer till they get worse. And then, of course, this is a pattern that you will recognize in all the following presentation. If a patient has to undergo surgery for another reason, let's say for coronary artery disease, to undergo bypass surgery for obstructed coronary arteries, and also has aortic regurgitation or a valvular disease, then since the surgeons open the chest to do that surgery, he or she should also correct the valvular problem. So you'll often see this indication 1, surgery is recommended in patients undergoing bypass or surgery for heart surgery for another disease. And then we use all these algorithms, as you see here, making these decisions by using, echocardiography data, if the patient is symptomatic or not, and when just to follow up the patient and when to send the patient to surgery. And surgery, we are using all these prostheses. We have the mechanical valve that you see here. This one is the very first, the very old, the ball cage valve is not used anymore. And most of the valves today, the mechanical valves, metallic valves, are bi-leaflet like this one. And then we have the bioprosthetic valves, all the rest here. And the decision which one to use in a given patient. Oh, it's a very long discussion that the patient should have with the surgeon, but in general, we have a tendency to give bioprosthetic valves to younger and younger patients today. So I believe in the US, if you're 60 or above, it's more likely to be offered a bioprosthetic valve. In Europe, we may be more conservative. The limit could be like the border of 65 or something. But we are going towards the bioprosthetic valves because usually they don't require anticoagulation, blood thinning therapies. So less hemorrhagic complications from anticoagulants. But of course, the problem with these valves is that they don't last forever, like the metallic valves, and they usually degenerate and they have to be replaced after 10 or 15 years. And I think the tendency is to use more and more of them today because the generation of such a valve doesn't mean anymore second surgery, redo surgery, because we can do that with catheters today. So when a surgical valve is generated after 10, 15 years. The patient did not undergo surgery, but we go with a catheter and put a new valve inside the old one. So we start the clock again for another 10, 15 years. And this is how surgery is done. So there's a photograph. This is the aorta that is opened. And this is a bioprosthetic valve that is implanted after they remove the thickened, the problematic, aortic valve. And the surgery can be done with various ways. So this is the classic or standard open chest with sternotomy. But surgery is advancing, and we have many new techniques that are minimally invasive. So surgeons can now have a right anterior thoracotomy, just a small opening here, or a mini sternotomy to implant the aortic valve. Moving to aortic stenosis, that, as you remember, is the most frequently treated valvular disease today, at least in the US. I believe the same is in Europe. So what is aortic stenosis? It's thickening, the generation of the 3 aortic leaflets, as you see here. There is accumulation of calcium, scar tissue, fibrous tissue. So the very thin leaflets of the aortic valve, they become thicker, very stiff, so they don't open with blood flow and they remain closed. And this is the aortic stenosis, obstruction of the flow. And these are real photographs. This is how the normal aortic valve appears. You see very thin leaflets. It's almost paper thin. And this is a stenotic valve. You see accumulation of calcium nodules on the valve, thickened leaflets. And as you expect, this valve doesn't open very well in systole. These are computer tomography, CT tomography imaging of the aortic valve, a slice of the aortic valve, and this is a normal aortic valve. So you see in systole, when the heart contracts, how the valve opens. This is the opening, and how thin are the 3 leaflets. And this is in diastole down here. And this is a stenotic valve, again, in systole. And you see, whereas the opening, the normal opening is like this, the opening here is just this line. So all the rest doesn't open because of the calcium, because of the thickening. It's even worse in this image down here. And again, to decide if aortic stenosis is significant, its hemodynamic impact is important on the heart function and on our body. We use echocardiography. This is standard for all valvular disease. Echocardiography is the way we judge it, the way we assess it. And again, we have very, very well established and defined rules on when an aortic stenosis is severe, as you can see here, and when it's moderate, when it's mild. So if we do echocardiography and we find this, we know that the patient has severe aortic stenosis and must be treated. If it falls into this class, moderate, in most cases, we follow up the patient, or we can use other modalities, imaging modalities, to better clarify the significance of a disease. As you can see, again, this very complex algorithm on these patients we use echocardiography data to define the type of stenosis, if it's severe, if it's moderate, and then we have some sub classification, because when we measure the aortic stenosis, we measure the velocity of the blood through the stenosed aortic valve. And this can be, this is a function of the narrowed lumen, but also a function of the flow. So if the volume of the blood exit the heart is lower, then the velocity will be lower, because it depends also on the volume, not just on the narrowing. So sometimes it's becoming more complex to assess the aortic stenosis. That's why we have this subclassification of low flow or normal flow aortic stenosis. And in these circumstances, we're using, as I saw to you earlier, CT information to define better the underlying pathology. So if the patient is symptomatic, the indications are pretty straightforward. And as we can see here, the European guidelines, we have class 1B if we have a symptomatic patient who has severe aortic stenosis in most cases. And then we have class 2A, level of evidence C, in those patients that they have what we call low flow, low gradient aortic stenosis, when we have to better investigate these patients to make sure that they have a true aortic stenosis and we're not fooled by the low flow situations that can be arising from low contractility or from very stiff ventricle that cannot accept a lot of blood so as to then pump it out. And if you have an asymptomatic patient, again, we have a class 1 indication when this heart is already affected by the aortic stenosis, so the contractility of the heart is reduced. This is a very ominous sign. So even if the patient is asymptomatic, it's class 1 indication. And then again, when these patients are exercising and the blood pressure is dropping, this is another ominous sign. So we send them for surgery. And then we have 2A, that in most cases we consider surgery to these patients when they are symptomatic, but they have signs from echocardiography or from the CT scan or this peptide, the BNP. You've probably heard of this BNP. This is a peptide that is produced by the muscle of the heart when it's distended. So when it's distended by various valvular disease, but not only valvular disease, the BNP levels go up. So this is a surrogate of the significance of the valve problem. So we look into other things and we may decide to treat a patient when the aortic stenosis is severe, even if the patient is asymptomatic. And the trend coming from studies nowadays is to treat these asymptomatic patients who have severe aortic stenosis without waiting for them to develop symptoms. And now for aortic stenosis, it's not only surgery. We also have, as I said earlier, the transcatheter therapies, where we do not do surgery. We go with a catheter from the leg, like the cornea angiography that used to be done from the femoral artery in the past, from the groin, and we implant the valve this way. So we do the replacement without surgery. And that's why both the European and the American guidelines, they give us some guidance as to when to choose surgery versus transcatheter replacement of the aortic valve in aortic stenosis. And then you'll see here that in most cases, these are the European guidelines. First of all, they tell us that this decision must be made in a by a heart team approach in a center of excellence, center where they are doing all these procedures. And I think everybody would agree to that. So if you go to a hospital that is doing only transcatheter valve, they will offer you transcatheter valve. If you go to another hospital that is doing only surgery, they will offer you surgery. So that's why it's important to go to a heart valve excellence center where every therapy is offered, where the heart team will decide what is best for any individual patient. So what you will see here, just to cut the corners and make it short, is that the European guidelines say that if you're 75 years or above, then TAVI, if it can be done easily, is a priority, should be offered first. If you are 75 years or below in general, then surgical replacement should come first in your mind. There are, of course, exceptions to this rule, because if you are very young, but your risk score, you have many comorbidities, is very high, then TAVI is offered. And if you're like 75 or 80, but you don't have any comorbidities, the surgical risk is good. And from all the investigation, it appears that the TAVI technically may be difficult for you, then surgery is offered. And they try to put on a table all things that favor TAVI versus surgical replacement. And as you see, AIDS is one of those. Surgical risk is important. If you have previous cardiac surgery, frailty, and then anatomical factors that we get from echo and from CT scan also play important role. So if a TAVI is technically easy, then it may be offered to younger patients, but if it's difficult for some reasons, and there are some anatomies that TAVI can be difficult, then surgery will offer even in more elderly patients. And these are the American guidelines. The American guidelines get a similar stance, but there is some difference in the AIDS borders, limits they're using. So basically what they say is if you have a patient that is 80 or above, go for TAVI. If you have a patient 65 or below, think of surgical aortic replacement. And if you have a patient between 65 and 80, this medium, let's say, elderly people, then you can use them both, taking into account in your decision-making all the factors, more or less, that the European guidelines put on a table. So basically, they authorize TAVI, transcatheter therapy, in younger patients than the European guidelines from 65 and above, if there are no negative factors, anatomical factors for TAVI or clinical factors for TAVI. And then you see the level of evidence here, B, A, and C, for all these recommendations that I think it's not time to explain them. And again, we have all these algorithms to make our decision, taking into account everything we discussed earlier. So for a given patient, we put here the information at any step, and you see the aids here, and you go down and you have your recommendation by the guidelines. So very quickly, this is how transcatheter therapy, transcatheter aortic valve is done. We go from the groin with a catheter, and then we pass a wire through the aortic valve. This is the stenosed aortic valve. Usually first we inflate a balloon to open that valve, to prepare it then to go with a valve. This is the valve, which is a stent basically with a bovine pericardium forming the leaflets in this particular device. So we go into the stenosed aortic valve. We position the new valve inside in the right place, and then we inflate the balloon. The valve opens, and now it's the new valve of the patient. So the whole procedure is done without general anesthesia, some local anesthesia, and sometimes with some sedation of the patient. The patient walks up on the same day, later on the same day, normally gets out of the hospital after 1 or 2 days and returns to normal activities very quickly. There is no surgical wound. So you understand this is not invasive at all. And the benefits and the advantages are very obvious. That's why most patients, okay, sorry for all this, I have to go back here. Most patients that are aware of this therapy prefer it, and they ask for it nowadays. So this is a real procedure. So you see, this is what we call aortography. So we inject dye into the aortic root, and this is the aortic valve at this level here. You see this black points here are calcium. This is how calcium on the aortic leaflets appear. And this is the valve. So, and this is the positioning of the valve. We rapid pace the heart so it doesn't move and it doesn't pump blood out. So we have stability of the valve, we inflate, and this is the result. So this is the new valve of a patient. So this particular valve is exactly the same in shape and in size with the surgical valves. Surgical valves that I showed to you earlier for the aortic regurgitation. For the aortic regurgitation, there's also the transcatheter option, but it's not so mature as it is available for aortic stenosis. And this is the take-up of this transcatheter therapy, the TAVI as we call it, transcatheter valve replacement in the US. You see the volume of TAVI expanding through the years and surpassing the isolated valve replacement surgery in the year between 15 and 16, and then surpassing the total surgical aortic valve replacement in the year 2018. So in the United States, much more aortic stenosis is treated with TAVI and nowadays in surgery. And you see the effect of the guidelines, how the guidelines are in this development of this new therapy. So we have the guidelines. American guidelines definitely say below 65, don't think of TAVI. But in reality, this is recent data, not very recent, up to 2021. So recent may be even more than what this slide shows. You see patients below 65, younger than 65. You see in the year 2021, half of them had TAVI and half of them had surgical aortic replacement. So the question is, sometimes the guidelines like follow the reality. The reality says that this therapy, the uptake of this therapy is much larger than what the guidelines dictate. The guidelines came out in 2020, and this data is from 2021. And this is another study up to 2022 from Northeast USA or New England. And again, you see the same finding. You see that TAVR is in 2022, it's almost 52% in young patients below 65, and surgical aortic valve replacement is 48%. Same thing in this study. So moving to mitral regurgitation, which is, as we said earlier, the most frequent valve disease. And this can be primary or organic, as we say, or secondary or functional. This is the normal mitral valve that closes and seals completely any return of the blood in systole back to the lungs. And this is a primary or organic when there is a defect on the valve. Something is wrong with the valve. So here it's prolapsing. Little prolapse, more prolapse. There is some primary or organic degenerative problem on the valve. So something is false with the valve. This is the primary organic, and the functional or secondary, the valve is absolutely normal, but the leaflets distant one to other because the valve is dilated. The heart is dilated for some reason. So you see the atrium is enlarged compared to the almost normal, and this makes the leaflets to distant each other. So there is this distinction of etiology in mitral regurgitation. Mitral valve is much more complex than aortic valve because the aortic valve is just the leaflets, but here you see mitral valve is not just the leaflet, it's also the annulus, the caudai, the papillary muscles. So mechanistically, much more many reasons can come into play for mitral regurgitation. And again, we have all the echocardiographic indices to tell us when mitral regurgitation is significant or not. And we have this a very well-established criteria for both primary mitral regurgitation and secondary mitral regurgitation. So good echocardiography, a good echo exam will tell us if mitral regurgitation is significant and should be treated or not. So putting again all the data of the patient and of echocardiography, we come down to offer to the patient the right treatment for him. The guidelines for primary mitral regurgitation when the valves are, no, this is for secondary, sorry. For secondary mitral regurgitation, it says surgery basically, or only if the patient has to undergo surgery for some other reason, like bypass surgery. And then 2A, we have TEER. TEER is a transcatheter therapy. I'll show to you. We go with clips and we get together, we bring together the two leaflets in the area of the regurgitation. So I was telling you that surgeons can repair the mitral valve or replace the mitral valve. And again, they use mechanical or tissue mitral valves. Indications again, class 1, as you can see in those who have symptoms and severe mitral regurgitation. This is for primary mitral regurgitation. For primary mitral regurgitation, surgery is the main indication. So TEER, as you can see, falls down to 2B. So surgery must be considered in most patients with primary mitral regurgitation. And this is the clips that we're using today, transcatheter edge-to-edge repair. That's why this is the acronym TEER, which is mitral TEER or tricuspid TEER. These are the two clips. You see MitraClip and Pascal, how they open and close, different mechanisms. But this is how it's done. So you see this is mitral regurgitation. The color that goes up is the regurgitation. Here you see a clip, a Pascal, how it's positioned. Everything is guided by echocardiography. We close it, and then you see there's no color anymore. So regurgitation is corrected by catheter, which is similar to TAVI. We also have mitral replacement with catheters, but this is experimental. This is one of the valves we have used with a catheter directly from the apex of the heart, a self-expandable valve, and this valve is now can also be implanted transcatheter with catheter without surgery. And this is 8 years after the implantation of this valve. In the mitral position, you see it works very well. Well, I won't stay in the tricuspid regurgitation. It's similar. You understand the concept. So first of all, it's echocardiography. Then based on the symptoms and the characteristics of the patients, we're using these algorithms. And again, for tricuspid valve is mainly surgical correction. You see a tricuspid valve, how it's corrected by surgery with a ring usually around it, or replaced. This is a replacement. And we also use the clips in the tricuspid valve. You see this color going backwards is tricuspid regurgitation. This is a clip that is implanted, and you can see how the color we had before disappears after the implantation of a clip. And this is how we can also treat tricuspid regurgitation with catheters. And this treatment with TEER is so new that is not into the guidelines now. So we expect the following guidelines next year to incorporate the clip treatment in the tricuspid valve. And now we also have replacement for the tricuspid valve. This is the valve we're using. This is approved. We're starting using it this year. And again, I'll show you, this is a valve, how we implant it, and this is when it's fully implanted. And again, it takes off all the color of the regurgitation. So wrapping up, guidelines are an excellent distillate of knowledge, but they're just guidelines. They provide the minimum knowledge required by good practicing physicians, and they're widely used for regulatory and payer decisions, but they cannot cover everything encountered in medicine, and deviations must be allowed based on clinical justice. Thank you.